Hello and welcome. My name is Sarah Stevens, and I have shared a short summary of my professional background at the end of these slides. The title of my presentation is Medication Safety Technology, CPOE and Order Verification. This is the relevant financial relationship disclosure for this presentation. These are the learning objectives that will be addressed during the presentation. These are the key abbreviations that will be used in this presentation. Let's begin by looking at this self-assessment question. Examples of clinical decision support references that may be linked in the electronic medical record include A. Drug shortage alerts, B. The organization's formulary, C. Policies and procedures, or D. All of the above. When we return to this question, I'll provide the answer and discuss the rationale. The medication use process is a critical component of patient care, and it begins with prescribing. This stage involves the careful selection of medications tailored to individual patient needs. The integration of computerized physician order entry, or CPOE, with clinical decision support enhances this process by providing pre-built order sets and orders, which streamline the prescribing workflow. Additionally, access to electronic references ensures that healthcare providers have the most up-to-date information at their fingertips, promoting informed decision-making. This combination of technology and resources not only improves efficiency, but also enhances patient safety by reducing the likelihood of errors in medication management. The implementation of CPOE has significantly impacted medication error rates in U.S. acute care hospitals. In 2008, about 34% of these hospitals had adopted CPOE, which processes an estimated 1.7 billion medication orders annually. Research indicates that when CPOE is utilized, there is a notable reduction in medication errors, approximately 48% lower compared to when it is not used. This translates to a national reduction of 12.5% in medication errors, equating to an estimated 17.4 million errors avoided each year. The findings from 8 out of 9 studies underscore the effectiveness of CPOE in enhancing patient safety and reducing the frequency of medication errors, which is crucial for improving healthcare outcomes. CPOE plays a crucial role in enhancing medication safety, as we've just discussed. It's essential that licensed prescribers effectively utilize CPOE for medication orders, as this can significantly reduce prescribing errors. Integrating clinical decision support is vital, especially in high-risk situations, to guide prescribers in making informed decisions. The governance structure should involve pharmacists and medication safety leaders to ensure accountability and oversight. During the pre-alert phase of clinical decision support, we aim to simplify the process, making it easier for prescribers to follow best practices and more difficult to make an error. Think of the design of orders, how they look and feel, and what can be selected or what's even presented. The alerting phase is where clinical decision support actively engages the clinician, providing passive information and reference links to added warnings and actual interruptions to workflows that need to be interacted with, or at its highest level, a hard stop where the prescriber cannot move past the alert or bypass it. It's very important to consider all levels of these warnings and how it impacts the prescriber workflow, ensuring that actionable warnings are clear and effective. Finally, monitoring the effectiveness of clinical decision support is critical to identify any workarounds that may undermine its purpose altogether. This can be done by monitoring alert override rates, for example, looking at the actions taken post-alert, and being aware of electronic health record functionality that may undermine CPOE strategies that were built, such as those within order sets when physician favorites are then utilized. A targeted approach is necessary for clinical decision support to prevent over-alerting, which results in alert fatigue and an ineffective system to prevent important errors and interactions that may harm patients. This guidance provided by Leapfrog is a really useful tool that's well referenced and provides specific and tangible guidance for health systems to align and optimize their clinical decision support to address these key risk points. For example, when looking at drug-drug interactions, which is a huge strategy that has to be developed within an organization, They suggest looking at your level 1 and 2 interactions, QT prolongations, duplicate therapy with NSAIDs and statins. For excessive overdoses, they look at things like a 10-fold overdose of digoxin, thinking about medications where if you have an egregious overdose, what could really harm patients. Wrong routes are really important, and also a tricky strategy to leverage in your EHR to avoid some of those issues, such as a subcutaneous medication being ordered IV in error. And then onward, with regard to drug disease interactions, such as giving an antiplatelet medication to someone who has bleeding risk, benzodiazepines for patients greater than 65 years of age, also including looking at guidance such as Beers criteria, stop-start criteria, to determine what are your highest leverage sort of drug age considerations to have implemented within your electronic health record. Of course, there's drug lab considerations, avoiding an ACE inhibitor in someone with hyperkalemia, and other monitoring considerations, an example being baseline LFTs with a statin being ordered at the same time. What I also really love about this reference is they address excessive alerts, which is really important. So we could implement all of the alerts possible in the EHR and look really good maybe if we audited pieces and parts of our alerting strategy, but the overall utilization would be terrible, right? Because the override rates would be very high and people would be ignoring the important alerts we're trying to provide to them. So this strategy also ensures that you look at your electronic health record alerting or clinical decision support and avoid nuisance alerts that we know to be that, such as NSAIDs used along with a thiazide type diuretic. So I would recommend utilization of this tool, at least looking at that, whether you're a Leapfrog organization or not, and also digging through some of the references they provide to give a start and sort of a framework around your clinical decision support strategy. Another useful reference for designing medication orders in the electronic health record is ISMP's Guidelines for Safe Electronic Communication of Medication Information. It provides recommendations for the safe presentation of electronic information in various categories, including everything listed on this slide: drug names, doses, dosing units, weights, measures, and directions, and addresses specific situations with certain types of medications, etc., which can be really useful as you're designing your electronic health record, and sort of provides a framework for the team that would be working on this design, which hopefully includes a medication safety professional to all be on the same page. For safe presentation of drug names, it's everything from a complete drug name, when to include the salt, and also some guidance on tall-man lettering, which they have an approved tall-man lettering list, and emphasizes the need to have that uppercase and bold, which not all EHRs and other systems we use within the med-use process can support. But nonetheless, that's what's recommended for effectiveness. And then also they go into some additional detail on how to effectively set up product selection menus and search choices. There may be some limitations in certain systems requiring, for example, an alphabetical list for your drop-down menu, which may or may not be problematic. So being able to tailor that and what order information should be presented to a clinician is an important consideration. Some additional information on medication information as well as patient information associated with med safety is included in this reference, which was last updated in 2019, but remains very relevant to our EHR builds and what we'd like to see for medication orders to improve their safe use. I'll now discuss the importance of order sets and panels to improve safety. Order sets and panels allow for the combination of consults, nursing orders, labs, and medications with added clinical decision support. Examples include a heparin infusion that is indication specific, such as having an order set for pulmonary embolism, which is different dosing than acute MI, as well as the appropriate lab monitoring and nursing instruction that is necessary to safely administer that infusion in an acute care environment. And another example are chemotherapy plans that are utilized for patients being seen in infusion centers. Specific defaults and instructions are utilized. Indications are also utilized, such as the example with heparin, or orders may be limited to certain age groups. The challenge, however, for effective design and maintenance is determining oversight and ownership. There are multiple different owners or champions that may have different requests and interpretations of clinical decision support tools. This can be onerous and time-consuming just to get consensus on a given order set. Another challenge is driving providers to the correct order set and hiding some orders. In theory, it sounds easy, but can be challenging operationally to do it correctly. The modification of orders and the loss of clinical decision support is another challenge with this. An example being physician favorites. So physicians can save a order set to their favorite and make modifications to it. And once it's in that environment, it's very difficult to update and change when necessary for something like a drug shortage, for example. And finally, the maintenance and integration with other technologies can be challenging, requiring many people and resources across an organization to facilitate. This slide summarizes electronic references that may be used within the clinical decision support system. Various references may be integrated within the electronic health record, including formulary information, use of clinical pathways and policies, all of which are essential for informed decision making. And it ensures that healthcare providers have access to critical information at their fingertips. The area within the electronic medical record a reference is linked is an important consideration. The clinician being targeted and the place in the medication use process the information is needed are two key elements to address in order to make a decision on placement of that reference. And finally, on this slide, an example reference is provided that alerts a provider on a national drug shortage. It emphasizes the need for alternative therapies and where to find additional information. The information is helpful, but also provides a great example of a passive informational alert that might be more effective as an alerting strategy that facilitates ordering of the appropriate alternative therapy at the time that that information is presented. This slide highlights the significant efforts made at the Children's Hospital of Philadelphia to enhance drug interaction alert systems. The primary goal was to minimize the number of clinically irrelevant alerts that can overwhelm prescribers and pharmacists. By collaborating with various stakeholders, including prescribers and clinical informatics teams, the hospital was able to identify and review the most common drug-drug interactions. The results were impressive. The median alert rate for a pharmacist dropped significantly, indicating a more streamlined process. Additionally, the reduction in override rates suggests that alerts are now more relevant and actionable. This initiative not only improves workflow efficiency, but also enhances patient safety by ensuring that critical alerts are prioritized. The study underscores the evidence-based approach taken in this project and is an excellent resource for others trying to do the same type of work in their organization. CPOE also has its challenges and unanticipated consequences. The white paper on computerized prescriber order entry medication safety, or CPOEMs, highlights the challenges faced by prescribers, such as difficulties in locating the correct drug and regimen due to variability in ordering processes and the overwhelming number of search results. The distinction between brand and generic names and whether the system allows for both also proves challenging. To enhance medication safety, the recommendations suggest implementing a CPOE design that accommodates appropriate synonyms for drug searches, ensuring that prescribers can easily find what they need based on specific problems or indications. This approach aims to streamline the ordering process and reduce errors, ultimately improving patient safety. The recommended reading by Schiff and colleagues underscores the importance of this research in shaping effective CPOE systems. CPOEMs also highlight significant issues related to the use of comments in free text fields in prescription orders, which can lead to confusion among pharmacists, nurses, and patients. The lack of standardization in these fields contributes to inconsistencies in prescription information, which can compromise patient safety. Recommendations include analyzing patterns to identify the need for more structured information, as well as addressing challenges like alert fatigue and the inconsistency of clinical decision support systems. Inconsistency in alert firing is noted for inpatients versus outpatients, brand versus generic names for medications, and also for allergy documentation. This reference also highlights the issue of lack of interoperability and effective communication between CPOE systems and outside pharmacies, which at the time of publication was rather common. It can lead to significant risks. For instance, drug discontinuations may not be communicated effectively, resulting in potential medication errors. Additionally, the reliance on paper for controlled substances and use of faxes or electronic transmissions further complicate the process. Although that's less common now, it still remains an issue in some areas of the country and in some systems. The widespread failure to track and learn from CPOE-related issues was a concern at the time of publication and remains a concern to this day. This can result in a lack of transparency in reporting and monitoring system modifications. It's quite difficult to understand how clinicians are responding to clinical decision support alerts, which is critical for improving medication safety and optimizing systems. Addressing these challenges remains an issue and is essential for enhancing patient safety and ensuring effective medication management. Now we will move on to order verification, which is essential for confirming the accuracy of medication orders. The integration of CPOE with clinical decision support enhances this process by providing pre-built orders and order sets that streamline prescribing. Additionally, access to electronic references allows healthcare professionals to make informed decisions based on the latest guidelines and drug information. This combination of technology and resources not only improves efficiency, but also reduces the risk of errors, ultimately leading to better patient outcomes. The adoption of CPOE with clinical decision support reached an impressive 96% among hospitals in 2016 and is likely higher at present. This advancement has effectively removed the transcription step, streamlining the process and reducing errors. However, there are still challenges, particularly in the transfer of information between different technologies. It's crucial to learn from past transcription issues, such as use of unacceptable abbreviations and the importance of standardizing them. Additionally, employing clear fonts has significantly enhanced readability. We must also be cautious about relying solely on one healthcare professional to interpret drug orders, as this can lead to miscommunication and errors. These lessons are vital for improving patient safety and ensuring effective communication within healthcare settings. The shift towards automated systems and order verification has transformed traditional practices in pharmacy. The role of pharmacist verification of orders has evolved from largely transcription to a more analytical approach, focusing on clinical evaluations and identifying potential errors. It's crucial to highlight the importance of independent double checks, an example of which is the pharmacist independently reviewing and verifying a prescriber order. The verification step also involves evaluation of bypassed alerts by the prescriber and also evaluation of additional alerts that may have been muted for the prescriber and are presented only to the pharmacist. Pharmacists play a large role in fixing orders, ensuring appropriate dosage forms and delivery occur. CPOE has also introduced new functionality called auto-verification to streamline ordering. However, there are important considerations that should be evaluated before implementing this technology, including some regulatory considerations, which we'll talk about next. Auto-verification is the automatic verification of medication orders without the traditional pharmacist review. This process not only streamlines operations, but has the opportunity to enhance patient safety by ensuring timely medication administration. However, this functionality is not appropriate for all orders in a specific unit, such as all orders in an emergency department. Auto-verification algorithms should be implemented, taking into account critical values and patient history, integrating clinical decision support tools to ensure that only appropriate orders are processed automatically. It's important to note that any orders that do not meet established criteria are flagged for pharmacist review, maintaining a safety net in the system. This dual approach helps to balance efficiency with the necessary oversight in medication management. The reference from ASHP provides further insights into the implementation of this process, which can be a valuable resource for those looking to adopt auto-verification into their practice. Having said that, it is important to note that regulatory and accreditation standards are not yet in alignment with technology advancements and may conflict with this approach despite its potential. This slide further illustrates the auto-verification workflow. Once a prescriber places an order for a medication, if the auto-verification criteria are met, i.e. the order isn't considered of significant risk that requires pharmacist review, then it would be immediately available for dispensing, and that could be by way of an automated dispensing cabinet, or it could be dispensed from a central pharmacy, for example. However, if it does not meet the criteria and is deemed to require pharmacist review, then the normal pharmacist order verification process would take place. This brings us back to our self-assessment question. Examples of clinical decision support references that may be linked in the electronic medical record include A, drug shortage alerts, B, the organization's formulary, C, policies and procedures, or D, all of the above. And the answer is D, all of the above. As we discussed earlier, all of this information is available to be linked within an electronic medical record. In conclusion, CPOE has made significant strides in reducing medication errors, yet it is important to recognize that new challenges have emerged. These challenges stem from various factors, including human interaction, the need for standardization, and ongoing maintenance of the system. While CPOE has effectively eliminated order transcription errors, discrepancies can still occur between different technologies. It's crucial to focus on enhancing clinical decision support during order verification, as well as understanding the evolving role of pharmacists in this process. By addressing these challenges, we can further improve patient safety and the overall effectiveness of CPOE systems. These are the references used to develop this presentation. Thank you for your time and participation.